Hello, folks. Today we will find an easy way to memorize the complications of myocardial infarction. So, not wasting much time, let's get started. Cardiac arrest. This is a sudden cessation of cardiac activity because of an unorganized electrical activity in the myocardium. This leads to an ineffective ventricular contraction that is a significantly decreased cardiac output, which deprives vital organs of perfusion. The absence of an immediate intervention, such as a CPR or defibrillation, may result in a sudden cardiac death. The most common cause of cardiac arrest after sustaining myocardial infarction is a ventricular arrhythmia, specifically a ventricular fibrillation, ventricular tachycardia, but it may also occur as a result of bradyarrhythmias, pulseless electrical activity, or an asystole. There are other causes that are equally important because they are potentially reversible, and here we are looking at the H's and the T's. Hypovolemia, hypoxia, which is quite relevant for myocardial infarction, acidosis, hypokalemia, hypothermia, and hypoglycemia. Toxins, tamponade, tension pneumothorax, thrombosis, and trauma may also be considered. Aneurysm is one of the most serious complications of acute myocardial infarction. A full thickness myocardial infarction may leave a fibrous tissue behind, which then thins out of the myocardium and does not contract during systole, but instead outpockets. So what I have on the right is aneurysm. And the question that you may get is, what is the difference between aneurysm and pseudoaneurysm? In aneurysm, the base is quite wide. In contrast to pseudoaneurysm, the base is quite narrow. Regarding myocardial wall, we can say that pseudoaneurysm is a rupture covered by the pericardium. So the yellow line is the pericardial wall, and in it you can see the clot. Now, in contrast to aneurysm, you can see the pericardial wall, but you can also see a thinned out myocardium and, of course, the clot in it. So, in pseudoaneurysm, there is dyskinesia, but in aneurysm, there is no contraction of the wall around the aneurysm. Another thing we can also say is that the risk for rupture with pseudoaneurysm is quite high compared to that of aneurysm. And aneurysm often occurs in the anterior or the apex, and pseudoaneurysm occurs in the posterior or the lateral part of the left ventricle. Arrhythmias must be recognized as one of the most common complications after sustaining a myocardial infarction. This may be in the form of a bradyarrhythmia, a tachyarrhythmia, or blocks, and this may predispose to a sudden cardiac death. A right ventricular failure may also be seen, especially with inferior wall ST segment elevation myocardial infarction. Clinically, this may present as systemic hypotension, edema, hepatic congestion, or even ascites. Reinfarction may also be seen from stent thrombosis. Pericarditis. Dressler syndrome, also known as a post-myocardial infarction syndrome, is thought to be an autoimmune reaction that results in the inflammation of the pericardium. There is a release of an antimyocardial antibodies to the damaged cardiac antigen. This occurs within 1 to 3 weeks after sustaining a myocardial infarction. Papillary muscle rupture may result in acute mitral valve regurgitation. Now, the question is, what is the difference between acute and chronic mitral valve regurgitation? In acute, there is no time for left atrial dilation, hence, the left atrial pressure increases significantly and leads to pulmonary congestion. In chronic mitral valve regurgitation, left atrium can accommodate more blood due to compliance. In general, you would see a prominent V wave on pressure trace as well as a pansystolic murmur. Systemic thromboembolism. The risk for this complication remains very high, especially in a large anterior myocardial infarction, which comes from a mural thrombus. There is also a risk for deep vein thrombosis or pulmonary embolism due to prolonged immobilization. Cardiac tamponade. This is an abnormal state of increased pericardial sac pressure from the accumulation of fluids in the pericardial space. This will then lead to a cardiac compression and a hemodynamic instability. Normally, the parietal layer of the pericardium is non-compliant. There are factors that can determine the severity of tamponade, one of them being the pressure in the pericardial space. The other one is the volume of fluids that accumulates in this part of the heart. And certainly a very important factor is the rate at which the fluid collects. So an example is a 200 ml of an effusion can cause an immense hemodynamic instability because it collects rapidly. In contrast, a 2000 ml may also collect gradually and will not cause such hemodynamic instability. So the rate of accumulation is very important, or it's an important factor that determines severity. Let us take a look at the pathophysiology. So what I have here is going to be a heart, and this part is going to be the right atrium. Then we have the left atrium, we have the left ventricle, and we have the right ventricle. And the mean right atrial pressure is usually less than 5 millimeter mercury. Okay, so the pressure in the right atrium is naturally low. So we are saying that in tamponade, there is a buildup of pressure in this compartment because of a collection of a fluid which is quite rapid. And that collection will lead to a cardiac compression. But which part of the chamber is going to be compressed first? Certainly, it is going to be the right atrium because the pressures in there is less than 5 millimeter mercury. Now, when that part gets compressed, the pressure here is going to increase, and that's going to build back into the vena cava. Hence, we're going to see a distension of the neck vein, and clinically, that's going to manifest as a JVP elevation. Okay? All right. Now, the next thing is that if the rapid collection of fluid continues, then there is going to be compression of the left ventricle here. And this is quite serious because this part is very important for generating the cardiac output. And you do recall that the blood pressure is actually a product of the cardiac output and the total peripheral resistance. The cardiac output is the heart rate multiplied by the stroke volume. Now, if this part here, that is the left ventricular chamber, is compressed, then the diastolic volume here is going to decrease because it is compressed. And when that decreases, certainly the stroke volume would also decrease. So a decreased stroke volume here would lead to a decreased cardiac output, hence the blood pressure would also drop. So clinically, we can also see hypotension as a clinical manifestation of cardiac tamponade. You would also hear on auscultation a muffled heart sound. Now together we call this Beck's triad. So it's important to understand that a careful bedside exam can help diagnose cardiac tamponade accurately and expeditiously. There can also be a prominent X wave and an absent Y wave on the pressure trace. Now let's take a look at another clinical feature of cardiac tamponade known as pulsus paradoxus. We would assume this yellow part here to be the thorax, and this blue part here would be the veins. So if you keep temperature constant, then pressure can be inversely proportional to the volume. So if you take in a deep breath, that is, you do an inspiration, then what you have done is that you have increased the volume of the thorax. Once the volume is increased, pressure is inversely proportional when temperature is kept constant, so the pressure in the thorax will decrease. So remember that there is two pressure gradients. The pressure in the veins is now high, and the pressure in the thorax is now low. So there is going to be a flow from a higher pressure gradient into a lower pressure gradient. The blood is going to rush from the veins into the thorax. At some point, physiologically, there is going to be a vasoconstriction, hence the stroke volume would decrease physiologically to regulate the amount of blood that is coming into the thorax. So physiologically, there is a decline in the systolic blood pressure when you take in deep breath. All right, this is one of the important things to remember when you're taking or checking somebody's blood pressure. They have to breathe properly. If there is any hyperventilation, it can affect the systolic blood pressure. So what we mean by pulsus paradoxus is that when you take a deep breath and the systolic blood pressure falls or declines by greater than 10 millimeter mercury, we call this pulsus paradoxus. So, on inspiration, the pressure in the jugular vein must fall appropriately. However, if it remains inappropriately elevated on inspiration, we term this as Kussmaul's sign. This is not a clinical feature of cardiac tamponade, but a feature of constrictive pericarditis. So, how do we discriminate between cardiac tamponade and constrictive pericarditis? The onset of cardiac tamponade is acute as a result of a rapid accumulation of fluid in the pericardial space. The size of the heart in cardiac tamponade is enlarged. There are no calcifications in the pericardial wall when it comes to cardiac tamponade, a feature which you see with constrictive pericarditis. So, pulsus paradoxus is also a clinical feature of cardiac tamponade, but Kussmaul's sign is a clinical feature of constrictive pericarditis. There is effusion in tamponade, but there is no effusion in constrictive pericarditis. In cardiac tamponade, you will see an absent wide descent on pressure tracing. Septal rupture of the ventricle is a fatal with a high mortality rate, especially without surgical intervention. It usually occurs about 2 to 8 days after myocardial infarction, and this may lead to cardiogenic shock and signs of heart failure. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.